are there. Now, does every state of shock have all four of these? No, but they have some component of the four. Most of them have all four when they're at the very end or at the late stages as well. So when we talk about early shock, your book calls it the compensatory phase, and one of the reason it is because you can still pull out. You can still have the ability to recover from this. So it's hopefully not going to kill you. So your lungs, you're going to start breathing faster because you're going to be hypoxic and you're going to try to be grabbing more oxygen. It makes perfect sense. So because you're hypoxic, you're going to start releasing the free radicals, which really start to damage the cell membranes, which is problematic as well. And you're going to have the activation of the complement and the coag system. Remember, your complement system really has a lot to do with your liver, and it's that inflammatory process, and it's those 30 plus proteins that get called into service, all those phagocytes, the monocytes, the macrophages, the neutrophils, and we're trying to, it's calling up the cavalry to try to fix things, and at this point, it's working. We're also going to call up the coag system, and as you will find out, or you probably already know, almost everything in every cascade leads to some sort of coag problem, all being too much clotting. So we'll be looking at DIC at the very last thing we look at today as well. So what happens to the heart? Your body will say, okay, we don't have enough oxygen, so we're going to increase our heart rates. We're going to increase our contractility. We're going to try to make things go faster to capture more oxygen. And you're going to have increased vasoconstriction. So in the early stage, your body will be able to compensate and close down the vascular bed and help you maintain a blood pressure. So sometimes one of the things that we'll be looking at the sepsis 3 protocol today, unexplained tachycardia can be an early sign of shock and sepsis. So yeah, we'll talk more about that a little bit. Okay. So vasoconstriction. So initially what happens is that you have this amazing ability to clamp down not only your arterial system, but a lot of your veins. Your body can clamp down, it's a calcium-driven process, and it can clamp down the vascular bed, that tunica media. It can shorten the fibers, and it can clamp down, and it can give you up to 25% more of your blood volume at the beginning. The problem with that is that if you are here for hypovolemia, it's going to mask that, because at first you're going to be able to compensate well for that. And this, especially for my couple of ER people that are in here, we have to be very careful with giving narcotics to people who are suspected to be septic patients or people who are hypovolemic, because that will take away this defense. So this is a wonderful defense, and if you give someone narcotics, then they're going to vasodilate and arterial dilate, and then you're going to be into trouble. So, but the nurses are really sharp about knowing what's what with that as well. Sorry, this is such a side note, but if you have ever experienced, and I don't know if you have yet, but you may, a patient who is in severe, severe pain. I mean, I'll tell you one of the worst ones I ever saw. We had a gentleman who his shunt, he was a hemodialysis man, younger man, and I've never seen this before, and his shunt broke, and it was squirting blood. I mean, this is gonna kill him, right? And we can't fix that shunt, you can't repair it, it's a mechanical thing. So the only thing we could do was, until we could get him to surgery, was tie his arm off. So his arm was dying. Do you know how much pain that caused him? We couldn't give him anything for the pain. And the reason is, he was just in such hypovolemic shock by that point that he was, I mean, screaming at the top of his lungs. And because his arm was dying, we were killing off his arm. So we were killing off his arm to save his life, and yet we couldn't do anything to help him. So there's times in your life, in your career, when someone will be begging for pain medication, and you just can't give it to them, and it's horrible. And anyway, so you have to be careful with those things, because most of the things we give people for pain will make them vasodilate. So we have to be careful with that. Okay, anyway, he made it, and and kept his arm. So that was a good start. Good end of the story. Okay, so in early shock, your body is still able to pull fluids from the tissues into the vascular bed, because we're going to be learning about everything that's going to start causing vasodilatation. All the cytokines are going to start causing vasodilatation and shock. And so at the beginning, they can do that. They can pull from the tissues and throw it into our vascular bed. But people who have protein defenses, this doesn't work on, because the oncotic pressure in their vascular bed's too low to hang on to the fluids. Who would be a primary protein deficit patient? What organ?
Liver.
Liver. Our liver people, our hepatitis, our liver cancers, anything that's wrong with the liver, these people they're not making the proteins, especially the albumin, and so generally speaking, if they have that hypovolemia, we're throwing albumin into them as fast as we can to try to give them oncotic pressure. In sepsis, we have increased capillary permeability, so this is the opposite of this. And so there's a leaching of fluids out of the vascular bed because of the capillary permeability, because of the cytokines that are floating around in the vascular bed. And if you have, if you're giving someone a lot of fluid and they're not maintaining their blood pressure, or you're needing a lot of fluid to maintain it, and there's no obvious case of fluid loss, or not bleeding massively out of a chest tube, or vomiting, or having a GI bleed or something, then you might suspect sepsis as well. Oh, one more thing I want to say about the fluid situation is that you will also at this stage stimulate your pituitary to get to sodium, to hold on to sodium and water. So your kidneys get the message, please don't pee. So let me turn that off. Okay, thank you, sorry. Yeah, okay. So in early shock, here we're starting again with the platelet aggregation. So the endotoxins, which we're going to see a cascade in a minute, and endotoxins will stimulate platelet aggregation. And most of the time it's in the form of microemboli, so it's really teeny tiny. And we'll be discussing this more in DIC. Very, 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 very common, especially in sepsis as well. And again, the complement activation, we'll be seeing the end product too of that intrinsic pathway and the consumption of the clotting factors that happen. And we'll be talking more about that in DIC. And the idea behind that is that you're kicking out so much in the way of clotting factors that you've used them up. So we call that consumption coagulopathy, which we'll be looking at more. Okay, so what happens in early shock is that you don't have enough oxygen, and so you go into somebody have a question? Okay, you go into anaerobic metabolism. And remember that in normal metabolism, you are using pyruvate and you are making really good, beautiful, high energy ATP. When you have oxygen, you make 38 millimoles of ATP. When you take the oxygen out of the factor, you convert without oxygen to lactic acid, which is why the lactate, while we're measuring that, and you only get 2. You get 2 millimoles of very poor performing ATP, and so the ATP production goes down, and everything you need to power the body really is reduced as well. You also have your sodium potassium ATP pump, and this is because of this is not working as well. So you have too much extracellular potassium, too much intracellular sodium and water, which causes cellular swelling and can cause apoptosis or cellular death as well. And you are holding on to calcium. You not only hold on to calcium, but as things are destroyed inside the cell, calcium is made and kept inside the cell, and calcium is very, very toxic to the cell as well. So the Axiom, so if you have, we're doing plasma lactates on all of our suspected sepsis patients, but they can also be on our other shock patients as well. All right, so we go from early shock into late and decompensated shock on our patients. So, and it's also called irreversible at this point. So the breaking down of the oxygen-free radicals, which is very damaging to the cell walls themselves. The release of the hydrolytic enzymes, which are acidotic, your cell wall, and your mitochondria, which is the powerhouse of your cell. Again, you don't have enough power to run it, and you start damaging it as well. We also release bradykinin, which is a very potent vasodilator. Then MDF is myocardial depressant factor. It's put out by the pancreas of all things, and it does what it says it does, and it reduces cardiac output. And so it causes myocardial depression, and then the splenic vasoconstriction, it means you're not getting as much to the organs themselves, so that's not a good thing either. And it's something you usually don't have in your body